Welcome, everybody, to the 10th annual second virtual student-led interprofessional poster session. I'm really so excited to see you here. I know that's not in the script, but welcome, welcome, welcome. We've made it through another really challenging year. And once again, you, the students, have wowed us with your commitment to collaboration and teamwork. And I'm going to hand it over to Chris now to describe what it is we're actually doing today. Chris.
Thanks, Shelley, and welcome everyone. Today we have presentations from 17 teams made up of over 80 students from 15 different health professions. All of this work reflects the difficulties of this year. We have a focus in one of the breakout rooms on telecollaboration. We have examples of transformative leadership. Everyone has had to lead in new and different ways this year. We did enroll 10 teams in the Interprofessional Team Immersion, and that included students and faculty from Rosalind Franklin University in Chicago as well. And despite the challenges that were present in this year, many students were able to complete research as well. Shelley?
Sure, thanks. So we're really delighted that President Herbert and Interim Provost Karen Pardue have brought us their thoughts and messages today.
So hello, everyone, and welcome to this really exciting event. I want to thank the Center for Excellence in Collaborative Education for inviting me here today just to say a few words and to congratulate our students on all your incredibly hard work. The posters that you're going to see today are the culmination of the students' work over the course of their time at UNE. And many of you are going to receive interprofessional honors distinction upon graduation, which itself is an impressive achievement. But the work that you're going to do speaks for itself. The quality of the work is incredible. And I'm just so very, very proud of you. And more importantly than any of that, perhaps, is the relationships that you've built in doing this work. Many of those relationships are going to stick with you and going to be with you for the rest of your lives. And I'm sure you'll appreciate that more and more over time. Interprofessional education, or IPE, replicates what you're going to find in the real world when you're in practice settings, where you're going to be forced to collaborate and work with colleagues across disciplines. So it's part of the real world, but at UNE, we start training our students early on in IPE so that they have the skills not just to participate in this space, but to lead in this space. And so we really are training you with the kinds of leadership skills that you're going to be able to, it's going to set you apart vis-a-vis your peers when you get out in the workspace. It does pay off. I could go on and on about the statistics and the data on IPE and how it improves patient satisfaction, patient outcomes, it reduces provider burnout, it reduces medical errors, and there's great data on all of that. But I think what's perhaps more poignant and impressive are the stories that students tell us. And I'd like to quote one of our alums who recently sent a quote expressing their experience. This person said, "Opportunities at UNE made more of a difference than I realized. My colleagues from other institutions envied my experience. It set me apart." And I think that says it all. So congratulations to all of the students participating in today's poster session for their hard work. And I also want to give a special shout out to the faculty, the professional staff, and the advanced year students who supported our students along the way to today's achievement. So congratulations to you all, and thank you.
Good afternoon, everyone. My name is Dr. Karen Pardue. I'm the interim provost at the University of New England, and I am so pleased to welcome you to the Center of Excellence in Collaborative Education annual poster session. Today, we gather to celebrate students and faculty who have participated this past year in interprofessional projects, programs, clinical experiences, and research studies. Collaborative team-based approaches to healthcare delivery are a signature pedagogy here at the University of New England. We understand that patients and communities realize the best possible outcomes when delivered in a person-centered, respectful, team-oriented manner. No one discipline can tackle the challenges and opportunities inherent in healthcare. Instead, this complexity requires that all of us gather and listen, learn, and respond together in a well-coordinated way to achieve the best possible outcomes for our patients, their families, and our communities. I am excited to learn this afternoon from the presentations, and I congratulate all of the students, the faculty, and participating community partners who have been involved this year in this important work.
Thank you to President Herbert and Interim Provost Pardue, and many thanks to all the faculty mentors, student facilitators, and CECE graduate assistants, and most importantly, the students who have made the extracurricular effort to travel virtually with us for a while this year and learn about, from, and with each other along the way. You've all done a very difficult thing very, very well, we think. We'd now like to present the 2021 M. Lisa Pagnucco Interprofessional Faculty Award. Shelley?
All right, I'm going to do this without crying, I promise. It is my distinct honor to present this award that we give every year to a UNE faculty member for outstanding achievement in interprofessional service. We are delighted to announce that this year's awardee, like Dr. Pagnucco, is from our School of Pharmacy, Dr. Emily Dornblaser. As accreditation standards for interprofessional education in pharmacy became, to say the least, more robust, Dr. Dornblaser, without hesitation, took on the task of integrating pharmacy students into UNE's interprofessional culture through shared classes, simulations, and new interprofessional honor micro-credentials. Dr. Dornblaser has earned her place as a UNE interprofessional champion. And Emily, congratulations to you. Here we go.
Thank you guys so much. It's wonderful. These are awesome. Well, thank you all so much. It's an honor to be recognized by all of you and all of the work that you all do. I really appreciate it. And I just want to thank all of the students for always bringing enthusiasm and willingness to learn and respect for everyone to all of these experiences. You know, we set the stage, but I think you guys are really the actors that make this happen. And so it's just an honor to always to work with you all. And, you know, we're learning from, with, and about, and I always learn from the students just as much as I hope you all learn. So I really appreciate it. Thank you guys.
Thanks, Emily.
Thanks, Em.
Excellent. Well, that's we'd love to start with a celebration, and now we're going to get into the nitty-gritty a little bit and give you some instructions about how to take advantage of what's happening today. So as you can see, the poster session will occur in 4 breakout rooms running simultaneously. So you'll have research, telecollaboration, leadership, and the team immersion breakout rooms. And in your brochure, you'll see the highlighted in yellow events that are connected with the line, and that indicates that you're on the live stream. So the live stream will start in research, move to telecollaboration, back to research, and then over to leadership for the pandemic plan presentation, and then to team immersion with the client-centered chameleons. Obviously, everyone has the chance to do their presentation, to play the video of their presentation in their breakout room, and then there should be 5 or 6 minutes for conversation in between. You can see on the left side of the screen that the timestamps are keeps things moving quickly, and it's important for us to stay on time because we would love to have you join us for the last 5 minutes. We're going to be recognizing a few of the really outstanding presentations from today. And if you get lost or confused or don't know how to move from room to room, just stay in the main room, and Lee Cody from communications and I will help to manage you moving into your breakout rooms. And so, Lee, if the breakout rooms are open, I think people can start to move and go to the track that most interests you.
Hi, my name is Mike Govin and I'm from Team Space. With me today is Lyric Jordan, Talia Coate, and Julie Shea. The aim of this project is to determine what methods were most effective in connecting with our patient during our telehealth visit. Telehealth is an emerging service that is being utilized now more than ever as it is being used to reduce the spread of coronavirus. Although telehealth increases access to healthcare for some, others may not have access to devices capable of virtual communication or may not be comfortable using such devices. It is unknown if health outcomes are better or worse with the implementation of telehealth, so we hope this experience will shed some light on how it can be used appropriately in today's world.
In order to complete this pilot study, we surveyed IPTI Team 2 members consisting of 4 girls and 2 boys through an anonymous survey platform. Participants were asked to recall their IPTI telehealth sessions and answer questions on what methods they used to establish a connection with the patient and which method, if any, they felt was effective. The survey revealed that the top 3 most utilized methods by Team 2 were positive reinforcement and words of encouragement, humor, and involving other team members in the conversation. However, the majority of the group reported that talking about the patient's personal interest was the most effective way to establish a connection with them.
Telemedicine has become a vital part of patient access and communication, but it also has its challenges. Team Space found that connecting with patients was significantly harder than in-person encounters. The team found it critical to connect with the patient on a personal level in order to establish a relationship. Once the patient felt comfortable with the providers, he was able to open up about his goals and medical concerns. The encounter also emphasized the importance of time. By being able to interact virtually, it gave the patient access which would not have taken place otherwise. We learned that in order to do our jobs as medical providers, we have to treat the person as a whole and learn who they are before addressing their medical concerns.
So in conclusion, our team really saw that humor, shared interests, a strengths-based approach, and an interdisciplinary collaboration really had the highest impact on building a positive rapport during our simulated telehealth experience. And for future studies, it would be really helpful to have a larger sample size to really see what factors contribute to this positive rapport on telehealth, especially as they increase. So we really want to thank Interprofessional Team Immersion for giving us this opportunity to work on a team. And also, we really want to thank our faculty mentors, Dr. Cramsey and Dr. Albina. Thank you so much for listening. Thanks for listening. If anyone has any questions or comments.
So team 2, great job on your presentation. I'm curious if any of your team members are willing to share kind of, it sounds like there were some challenges just making those connections, as well as some things that you anticipate bringing into your future practice. So if you don't mind just kind of recapping sort of what the challenges were and what you think mitigated those and how you'll use it in the future.
I wasn't sure if my volume was off because it was quiet and I'm like, is my volume working? So I think that one of the biggest takeaways, which we said, was just the importance of establishing a connection. And I know for me, as someone who wants to go into pediatrics, telehealth has been a major uprising thing because you don't have to bring a patient into the chair to have these desensitization appointments. So I feel like not only did I practice the ways to establish a connection over telehealth, but also it just reconfirmed the importance of getting to know your patient on a more personal level and not necessarily just on a medical level. That's something that I will definitely carry forward with the rest of my career, whether that's with adults, pediatrics, geriatrics. I think it's very beneficial. And I really hope that groups in the future that do team immersion look at this and think maybe they could take this sort of pilot study and grow it and be able to pull more than just their specific IBTI group. I think that would also be really helpful.
Yeah, I think going off of that, in the beginning, it was kind of, I think, uncomfortable for us because it might have been one of our first telehealth experiences or just like working on an interprofessional team. And I felt like like not being in person, it was hard to kind of like try to gauge eye contact and body language, especially based off of like where the camera was for our patient. So it really did help us just kind of like use that humor and like use our shared interest to kind of get the ball rolling and kind of like break this almost like too professional of a medical team, just to kind of be like, we are humans too, like we want to get to know you and we also like want to be able to help you.
I'll ask a question. Were there any surprises or unexpected outcomes in this? Something just really took you, you weren't expecting?
I think what wasn't surprising, not to flip your question, was the results of what everyone found to be most effective. However, when we surveyed our group in the most utilized methods, establishing that personal connection with them actually wasn't one of the highest results. So that was definitely surprising because the methods we were utilizing and thought that would be important, like asking about their medical history and things like that, weren't what showed up in the results. So that was a little bit contradicting, but it was a pleasant surprise, I think.
I think to answer Dr. Cramsey's question, just being able to, I think I think it was Talia who asked him like, oh, what's your hobby? And he kind of said guitar. And I feel like it just kind of like turned into like, oh, like that's awesome. And we just started rolling with like where the guitar stores and stuff like that were. And like things just kind of got really so much more comfortable after that question. And it was just such a simple question, but it was so helpful to like make a good connection.
Yeah, I think really how it showed how important it was to read body language even through telehealth, because he was a very monotone patient. And when we brought up the guitar, his body language, opened up. And I think being able to read that and saying, oh, I think he wants to talk more about that, and taking that idea and running with it was essential for us to be able to actually provide good recommendations for his mental health and his total well-being, because we were able to tie the interest of guitar into his job search and other things like that, which was really helpful.
Just to get the ball moving, you can move to different breakout rooms if you want, but I'll be putting up a new transition slide, and the next one starts at 12:20.
Hello, my name is Brandon Thompson, and I'll be joined by my colleague Aaron Walsh as we discuss and share our poster presentation with you all. Special thanks to Dr. Thomas Mauser, who served as the principal faculty investigator of the present study. The title of the study is Self-Reported Cognitive Decline, Differentiating the Worried Well from the True Cases. Understanding the differences between normal age-related changes in memory and thinking versus cognitive change that might be associated with diseases such as Alzheimer's or dementia is important, especially in an era of continual medical advancement that has resulted in an increase of our elderly population. Cognition changes in normal aging adults typically results in slower, less accurate decision-making or processing external stimuli at a slower rate. Age-related diseases such as Alzheimer's accelerates the decline in neuronal functioning and consequently cognitive decline, which has a detrimental impact on the individual's ability to perform activities of daily living. Participants of the study were selected by the study coordinator and the director for the Center for Excellence in Aging and Health. Study research teams are made up of a variety of health professionals, including social workers, pharmacists, and occupation therapists. Phase 1 protocol involved a short interview with the participants that assessed their reason for participating, their hearing and vision, daily life, health, and cognition. This was followed by the testing portion of the interview, which involved 6 cognitive tests. Pictures of these tests are shown here on our poster. Data was then collected and analyzed to determine if participants would be categorized as true cases or worried wells. We utilized these preliminary results to select certain participants to complete a phase 2 interview process. We plan to analyze this data as a whole and will leverage our findings to not only assist those who are true cases to find a path to proper treatment, but to advance our knowledge of normal cognitive aging and other changes associated with true cognitive diseases. Thank you.
Thanks for that overview of our study in phase 1, Brandon. I'm going to take over from here to discuss phase 2 and some preliminary outcomes. After phase 1 was completed, participant scores were analyzed. 72.5% of the participants fell into the worried well category, whereas 15% were considered likely true cases and 12.5% possible true cases. A subset of 20 participants were chosen for a phase 2 follow-up interview. The aim of phase 2 was to further understand the participants' activities, health, and wellness in the context of their daily lives. Finalized results from phase 1 and 2 are expected to be released this summer and will answer questions like, do persons identified as a true case differ from persons identified as a worried well in terms of health conditions? Our hypothesis is that true cases will have evidently more health conditions than worried well, and that the types of health conditions will differ between the two as well. We expect the true cases to present with more CNS and heart-related conditions than the worried well. Thank you all for listening to our brief synopsis of our ongoing study. We welcome any questions you may have during our breakout session.
All right, thank you for listening, everybody. We'll take your questions, and I'll post the poster in the chat as well if you guys want to take a look.
So nicely done, folks. I'll go ahead and pitch questions. So as you got to know these people during the interview, you may have developed kind of a sense for them, and then you tested them and learned actually how they performed. And I'm wondering if you experienced any disconnects between how the person presented to you and then what you actually experienced with their testing in terms of maybe those that struggled and didn't do as well. I'm curious if you have any reflections on the clinical experience of assessing someone suspected of having cognitive impairment.
Yeah, I can start with that one, Dr. Meeser. That was a really great question. I think it really kind of depended on where we were in the interview with the patient specifically, and kind of if you guys were in the breakout room for the first presentation, I think it kind of associates with that. If we're talking to a patient who might be kind of closer to the side of a true case, but we were talking to them about something that they're interested in, they seem to be a lot more engaged and involved in the questions regarding that. But if it was something, you know, more about their health and how they're feeling about it, for me personally, I think I started to notice a little bit more of a disengagement in the patient. Whereas with the worried wells who didn't really have any true dementia symptoms going on, regardless of what type of question was being asked, they seemed to be pretty consistently engaged in the interview process throughout.
We'll keep the conversation going, hopefully. So as an OT faculty member, I'm just curious what it was like to give 6 different assessments to the individuals, and if you had familiarity with those tools prior to this project, what it was like to learn them and then to implement them.
Yeah, I'll take this one. For me, I've never had experience administering a cognitive test before. So the process was definitely new for me, but I thought it was a very enlightening experience. I enjoyed my time working with I work with a social worker, which is great. And in terms of administering the test, it took some practice. So we had some practice sessions to make sure what we're doing was correct. And once we got rolling, like the first couple were a little difficult, but once we found like our groove, we could just do it pretty easily, and it was very, very seamless working together with my partner. So overall, it was a really great experience.
Yeah, if I could just kind of, go right ahead, Dr. Dornblaser.
I was just going to follow up on if you could talk a little bit about how having this be an interprofessional experience maybe impacted the learning that you guys had.
I was actually my response is going to go right there. I was going to say, you know, as pharmacy students like Brandon and I are, you know, initiating these cognitive tests is something we aren't trained in. We're the medicine people. We do a lot of these point of care testing, things like that, nothing super cognitive. So to take these extra Zoom meetings to learn these cognitive tests and stuff, it really gave me more of appreciation to our occupational therapists and our other interprofessional team members. It really gives you more of an insight as a pharmacist to potentially what medications they may need, may not need, just based on these cognitive tests. So it really just opened my eyes more to really how important an interprofessional team is to treat a patient to the best of our ability.
And from an OT perspective, to hear that like what my results from like these cognitive screens would like change the medication that you're gonna give, that's interesting as well. Like, I know, a little tangential, but
Thank you, everyone. This is your time to stay here or go into a breakout room. That was an awesome presentation.
Thanks, everybody.
Thank you.
Bye, guys.
Hello, and thank you for joining us. We are pleased to present our poster on medications and cognitive aging in community dwelling older adults. My name is Emily Poirier, and I'm a third-year pharmacy student.
And my name is Kylie McKenna, and I'm a second-year Master in Social Work student.
Carly and I participated in a study of cognitive aging led by Dr. Muser as an assessment team. Our role was to meet with community dwelling older individuals via Zoom and administer a testing protocol. I was interested in the relationship between the presence of potentially inappropriate medications in older adults as identified by the Beers list and cognitive patterns. Our purpose was to identify if there's an association between the use of Beers list medications and associated factors and indicators of cognitive impairment in community dwelling older adults who report subjective memory complaints. The data that we collected from each of the participants was analyzed using correlation and mean difference statistics. We expected to see a relationship between participants taking Beers list medications and worsened cognitive testing scores. However, no obvious relationship was identified. We did find one correlation between anticholinergic burden score, which is the sum of all anticholinergic medications, and the short blessed test. Our analysis also indicated a correlation between polypharmacy, which is the use of multiple medications, and possible cases of cognitive impairment.
We have examined one of our participants with the possible cognitive impairment more closely. This is Jane Johnson, and she is an 81-year-old Caucasian female. Please refer to our poster for more of a social history on Jane. And Jane reports the following health conditions: hypertension, arthritis, history of smoking, and suffers from poor sleep. She is prescribed the following medications to treat her health conditions: metoprolol, lisinopril, and HCTZ. She also reports taking over-the-counter Benadryl. In January 2021, Jane participated in the following. She reported a worsening of her memory and thinking, particularly with remembering names, and she reports no family history or memory difficulties or cognitive changing or decline. Jane was given numerous cognitive tests over Zoom, and she took the SAGE and scored a 16. The score of 16 on the SAGE is consistent with mild cognitive impairment, and as previously mentioned, Jane takes Benadryl, which is identified as a highly anticholinergic medication by the Beers list, and can contribute to cognitive impairment, confusion, or sedation. While we did not find the results or get the results that we expected, this was just a small sample study that was good for first step and provided a lot of pilot data for a larger research study that Dr. Muser plans to pursue.
Thank you for sharing. Does anybody have any questions or comments? I guess I have one. Dr. Muser, for your future research, is there anything from this study that you're going to change about that, or just kind of think about a little bit more based off of these findings?
Sure, thanks for asking, Julie. So we all hear these warnings with medications. It might affect your driving, or don't operate heavy machinery or whatnot. And we generally think about certain medications as not being appropriate for older adults. And I dropped a copy of the Beers list link into the chat for those that want to look it up. It's actually good for all health professionals to know something about Beers list drugs. Our sample size was too small probably to see much of a signal, although in the case that Carly read, we definitely had a recommendation, time to stop Benadryl for this one person, probably. At least it's something that she needs to take back to her primary care doctor. The hope is that we can get a grant to do a much larger community sample where we can both test people and learn about their medications and see a signal for drug impacts in the future. And I'll ask a question of Carly, just, so you, as a social worker working in an interprofessional team, you evaluated these participants. What was it like working with somebody from a pharmacy perspective in this? And did you learn something new about that you didn't know before?
I give all pharmacy students a lot of respect for pronouncing any of the medications. Emily was really kind and generous with how many recordings that we did for me to even come close to it. But just from a medical perspective, it was really fascinating to see, you know, what Emily picked up on during the interviews versus what I would pick up on in terms of, you know, mental health and social setting and people like relationships, whereas Emily was more focused on, you know, the medications and how they're working together and how they could be affecting her cognitive change. So I did learn a lot.
Yeah, terrific. Thank you. Any last questions for Carly Rye? Since there's time, I'll mention that Emily Poirier wanted to be with us, but she's traveling to see her family today and couldn't participate.
My name is Faye. I'm a social work student. I'm Corey. I'm an occupational therapy student.
My name is Christine. I'm also a social work student.
And we're going
to... For our project, we created a body map.
So here it is. So a body map is an arts-based social work intervention. It's used with a number of populations from LGBTQ youth to sex workers to immigrant communities. What you do is you'll start with the outline of your body, and the inside is going to represent your values, what's important to you. The outside is going to represent your supports, who and what are important to you and support you. So we decided to do it for each of our fields, and we'll have Corey start with the occupational therapy.
So on the left there, I'll start with the inside of my outline. I do have a tree that represents family. I've always grown up around animals. I enjoy traveling and hiking. And on the outside on the left, I have AOTA, which is our governing body, which is the American Occupational Therapy Association. I have some popular models that we use. I have also different technologies that we might use in practice, and also different drawings representing everyday activities that we may do with clients. And on the bottom there, I have the Just Right Challenge, which is something that we strive to do with each client.
So for the social work side, Faye and I did ours together. So our inner body represents, you know, the things that helped us get to our social work career. So we both like to help people, as well as we have interests in being outdoors and spend time with our pets and family. And on the right-hand side, on our outer body, we have the things that we care about in our fields, which is social justice and policy issues. And on the bottom, it shows the theories that we use. We do micro, meso, and macro work. We do work with motivational interviewing and polyvagal, and we also create safety plans.
And on the this area here that is in between us, we represented the aspects of our fields that overlap. So we do mental health work, CBT work, communication is very important, client-centered care. We work with families, we work with evidence-based practices, ethics is important, and mindfulness is important for both of our fields. And up here, we work in a lot of different settings. And that was our project, and thank you. That's our time.
You kind of talked about, I think it was one of the social workers, you kind of talked about how it's done in practice. Is there like typically like a age range, or is it more like a type of situation that the client is that you would use this the most, or is it just?
Use body mapping?
Mm-hmm.
It's been used with youth, but also adult populations. There was I think Indigenous women in Canada, there was a body mapping thing that went for like a couple of days, and each woman made their own map. So yeah, really any age.
Was there anything that surprised you? Sorry to cut you off. But was there anything that surprised the group about like what each person put in the middle or like anything?
Yeah, I think that we were surprised that we had so many similarities between our fields, kind of seeing, the things we're like, oh yeah, we do this. And like, do you also talk about this? Or, and some of them are pretty obvious, like client-centered work and, but evidence-based practice also, and mindfulness and, obviously we all work with family systems. So it's just a lot of similarities that we didn't really think about or realize until we started doing this project.
Thank you guys for a great presentation. It sounds like you gained a lot of positive outcomes as students, learning about and appreciating each other's professions. I'm wondering, in practice, what are some of the positive outcomes that result from body mapping interventions?
It can be a useful, arts-based social work can be really useful for groups that are gonna get something out of doing art creative work. So like populations that don't like immigrant populations who maybe the people who are if they're doing it here and they're not from the US, maybe they can represent more with pictures and drawings. And, it's like a sense of accomplishment. You've made this beautiful work of art and it represents you, and it's kind of can give you just a sense of, I guess, accomplishment and satisfaction.
Thank you guys.
I'm also wondering from like the OT perspective, like if this could be helpful, like we talk about interoception a lot. I don't know if this came up like while you were just like making this, but like kind of understanding like what is going on inside of your body, like what those feelings are. And if that could, like, even using like this body mapping could help with kind of understanding like, why does my stomach hurt? Why does my arm feel like that? Or why do I feel so like anxious right now? So it was really cool to see that visual of like all the things that you love. And yeah.
I also think, doing this, I learned a lot about kind of this way of doing things. So I think it can give people a lot of voice too. So also kind of, having those representations of things that they may want to talk about or they may not feel comfortable talking about. I thought that was really great too. Yeah.
So I'm curious of the three of you that did the body mapping. Do you feel like you're creative? Are you somebody who seeks the arts, or was this outside of your comfort zone? And how might that translate or not to clients that either feel like they're crafty or creative, or perhaps more nervous about what the outcome is? Because the products are beautiful.
I can say that I am not artistic at all, like at all. Like, I can see a photo. I had my phone up and I was Googling photos on, interpreting what I wanted to kind of say. And then when I would draw it out, I was, at the very end, I was very proud of our work. I was actually in awe of it. I stared at it a lot. I kept like referring back to like, look at what we made, and it made me feel really great that we were able to do something and put together. I think having someone facilitate the body map who is, interested in art. We had Faye in our group who was interested in art. Really kind of brought like, she kind of taught us how to do certain like painting strokes and how to blend colors. And I think that part was really fun.
Thank you so much. And this is kind of a time to stay in this room or move to a different one if you'd like. And the next one starts at 12:47.
So thank you everyone for joining us. I will be kicking us off, and our presentation is called The Biopsychosocial Implications of Chronic Pain Care. Next slide, please. So I'd like to introduce our team. My name is Belle Bokel. My pronouns are she, hers, and I represent the School of Social Work. Some team members are not able to join us today, but Stephen Chang, he's an OMS 2 from the College of Osteopathic Medicine. Shamim Vakori, also also from the College of Osteopathic Medicine, OMS 1. Rosita Zinyatolova, a PA student, Erin Ahmed, who represents nursing, congratulations on graduation, and our own Dakota Rogers in OT. I will also be leading us through the treatment process that we undertook this semester. So we had 3 collaborative team meetings. We had 3 interprofessional telehealth appointments over Zoom. And our collaborative process included document sharing on Blackboard, email collaboration in the in-between, and we looked at telehealth via Zoom. Next slide, please. So we'd like to introduce you to our patient, Mr. John Doe. So we've changed our patient's name just to talk about HIPAA compliance and to share some details about him. So Mr. Doe identifies as a husband, a father, a grandfather. In one of our sessions with Mr. Doe, he shared a quote that I'd like to share with you. Everything is for them, meaning his family. That really resonated for us. Mr. Doe, from a medical standpoint, came to us because he has a long-standing chronic pain history. We also found out that he had a long-standing substance use disorder, specifically with alcohol. So it came to reason that during treatment, the recognition that his alcohol use was definitely impacting his movement, his sleep hygiene, the ability to provide for his family, and he shared with us that this was killing him. Some of the things that were important and started to come up in care was that he had a supportive partner that was actually in sobriety. And even though we were in the midst of a global pandemic, very close to his neighbors, strong network of friends, adult children that lived within 30 minutes and was able to see his grandchildren. So that was very important. Next slide, please.
So I'll be taking over this.
Yes, I'm going to kick this over to my partner. Thank you, Erin.
Yes, of course. Our initial impressions of care when we first met our patient, our team was concerned. Our patient has a very long and detailed complex medical history, including many neurological challenges that played a part into his chronic pain management, as well as a 25-year history of chronic pain with minimal relief. Our team identified that, of course, pain management, different techniques was the priority, as well as further injury prevention. However, as my colleague Belle said, substance abuse disorder really became a big factor with our patient, and we realized that we were going to have to undertake some new creative work on how to open up with our patient and investigate this some more. And it was definitely a secondary factor and a huge part with his treatment. Next slide, please. The execution of care. During our second meeting with our patient and during our debrief afterwards, it became very evident to us that the substance abuse disorder was going to now take the priority and would actually not really be a secondary factor, but plays very well hand in hand with the chronic pain our patient was suffering from. We needed to begin addressing the pain symptomology of our patient and begin to really focus on these mental health concerns that we had. Namely was the need to abstain from alcohol in order to prescribe buprenorphine as a pain management medication. Next slide, please. And bringing back the biopsychosocial, we're returning to the basics here. While initially concerned with the biological factors of our patient in relating to his chronic pain, it became evident that this was now a big psychological and social issue, and that we really needed to focus on holistic care in order to make sure that we encompass all dimensions of proper patient care and health influence in patient well-being.
Now we wanted to just discuss from our own perspectives our initial impressions and how that changed through time. I'm also just going to be cognizant we have about a minute left, team. So I know that initially I was concerned primarily with the pain and from an occupational therapy standpoint and from his physiological physical symptomatology of pain, and he was already using so many different methods to alleviate that pain that it became evident after our second appointment how important that mental health aspect was. And I'll pass it to a colleague.
I'll quickly just say my big takeaway from this experience coming from nursing. I personally believe that a nurse plays a little bit of every role in the healthcare team. And my big takeaway from this was how important it was to include the interprofessional care team with our patient in order to make sure that they get the best care possible from all members of a healthcare team.
Yes, I'll definitely piggyback on what my teammates have said. Studies are showing that issues around mental health may soon be the most common pre-existing conditions that we're going to see as healthcare providers. So as I think back to our patient who came to us with really complex chronic pain and a surfacing trauma history around substance use disorder, it really only strengthened the need for interdisciplinary training like this experience. And I don't want to speak for the team members that aren't here, but that was helpful for us. So we're just really thankful for this experience.
Thank you so much. Thank you all so much for listening. And now we have a minute for questions and any transition. Well, it's been very wonderful working with this team. It was a great experience.
Dakota, this is Frank Brooks. I have a question.
Yeah.
I wanted to hear from team members on how they think telehealth improved or made harder communication with the patient.
That's a great question, Frank.
In our case, we believed that telehealth was a great benefit, particularly in our second meeting. Our patient's significant other was able to join us on the call and offered some great insight into the patient's home life. And we personally believe that it helped our patient open up a bit more to us with her present.
I'll piggyback on what my colleague said. And it was so great to see from a nursing and an OT, because at least in School of Social Work, we're not always exposed to all of those factors from the micro meso, from micro meso macro. But when we were in the home, and I take that responsibility very, that's a huge honor and a privilege, but not only meeting the patient's significant other and hearing their stories, but being in their home, because telehealth, is being in someone's home. And so, them sharing that they're building a home, them sharing, where their dog walks and scratches the steps, them sharing all the noises in their yard and where the bird feeder is. That's an intimacy that we're not getting in the hospital. And so that we're all, my dog was barking in one of the appointments, and there is a relationship building strategy that telehealth gives us access to. And so I think that was a huge part of that.
Thank you all.
My name is Brian Simpson, and I will be reading a brief overview of the poster. Chronic pain is a serious classification on pain is insufficient, which leads to inadequate pain care from postgraduate healthcare conditions. The Mercy Pain Center, under the direction of Dr. Stephen Hall, has worked with uni students for a number of years to provide an interprofessional student training experience.
My name is Jordan Simpson, and I will be reading a brief overview of our poster. Chronic pain is a serious health problem growing in prevalence with an immense financial and social cost. Current medical education on pain is insufficient, which leads to inadequate pain care from postgraduate healthcare clinicians. The Mercy Pain Center, under the direction of Dr. Stephen Hull, has worked with uni students for a number of years to provide an interprofessional student training experience with chronic pain patients to meet these issues. In learning about interprofessional teamwork during the COVID-19 pandemic, we discovered that this approach allows for diverse experience and skills to be present at the table, and allows for more holistic approaches in appointments and care. It places an emphasis on providing patient-centered care. By listening to different perspectives during meetings, we gained a greater understanding of each other's disciplines, and we were able to support one another as needed when unable to attend patient appointments. Overall, collaboration was crucial in establishing rapport with each other, our mentors, and our patients. Zoom presented many advantages for the patients, providers, and students. Zoom allowed students to participate in the pain clinic experience who otherwise would not have been able to. It allowed for schedule flexibility. It eliminated barriers for students such as transportation and increased commute time. Zoom allowed more options for patient appointments. More students from different majors were able to attend appointments and participate in meetings. safety, and privacy was established for the patient by turning off our cameras when not speaking, as well as upon request. The patient could have joined the appointment from home if she couldn't make it into the office. Zoom allowed for involvement of a loved one for comfort and support, or another provider to assist in meeting barriers such as healthcare literacy, translation, and more. Zoom does present challenges in gathering accurate information and conducting a successful appointment, and may include physical examination limitations, technology challenges, and challenges in comfort with Zoom, with obstacles such as loss of human connection and authenticity, difficulty in engaging with and viewing nonverbal social behaviors, and additional distractions such as coordination of students during the appointment. By working on an interprofessional team via Zoom, students were able to provide patient-centered care in a telehealth setting. Zoom allowed students to be present at selected appointments when available and created an environment in which collaboration and communication were essential in establishing rapport with the client. This experience was beneficial in learning how to approach pain from a multidisciplinary perspective. Thank you very much for your time and attention. We'd like to give special thanks to Dr. Hull, Dr. Sao, Kelly Fox, and Dr. Lee for their advisement and support during this project.
Comments from our team. I had a quick question. I think I can ask it faster than I can type it. As a pharmacist, I use telehealth a lot in my clinic, and I'm curious about the idea of turning off your camera and making the patient feel more comfortable, because the patient may or may not know that they can still be seen even though your camera is off. Any thoughts on that?
I can take this one. Yeah, so our client knew that who was in the room, and we introduced ourselves at the beginning of the meeting. But because there were so many of us in the Zoom, we just turned off the camera so she didn't have to see like all of our faces looking at her, but she was aware that we could see her. And that seemed to work for her. And when she did want to just talk to the doctor separately, we were able to like leave the Zoom for her to be able to do that.
This is Frank again. I'd like to ask team members what their number one takeaway was from this project. I mean, you've listed a lot, but just individually, what did you take away regarding interprofessional education?
I can go ahead. I would say I learned just a lot about the different perspectives that other healthcare disciplines take when managing types of pain. It was really interesting to learn about like pharmacy and other disciplines I haven't been able to work with quite yet. I didn't have experience working with pain at all, and just learning about like pain management in general, I thought was really interesting.
Thank you.
Yeah, it's been so interesting to hear the other team's experience with the pain clinic.
Any surprises? Something you didn't expect?
They're great questions, Frank. I'm curious about those too.
I would probably just say the most surprising thing to me was that pain can come from can manifest in different ways. Our particular patient had, I believe she had knee problems, but she ended up having pain like elsewhere in her body. And I thought that was really interesting. That was surprised me most, that it didn't have to be just exactly where her knee was, like it manifested in other areas.
Thank you so much, presenters. And now we'll be moving.
Our interprofessional project, we were a part of the telewellness project that assisted older adults with technology use. So for our research question, we had two. The first one was, how can different perspectives help assist older adults in understanding and learning telemedicine? And the second was, can utilizing motivational interviewing help encourage older adults to learn technological devices? So we were paired together with a specific older adult, and our older adult lived at 75 State Street, which is a residential program in Portland, Maine. She has never owned a tablet, and she was unfamiliar with how a tablet works. For this purpose, we are going to call her V. She is a mother of 2 and a grandmother of 4. She is also a widow, and she enjoys spending time with her family when they are in the area. She is quite soft-spoken and friendly. She was open to discussing various topics with us, and she was able to listen and communicate with minimal issues or challenges through the tablet as well as through the phone.
So the process of this project was that we were assigned working with our older adult participant, and helping her to learn how to use the tablet. And we did so by talking on the phone with her at first and explaining how to use the search engine Google, how to open and operate Zoom, and how to open her email. So over the course of 7 weeks, we were able to help her learn all the different features of her tablet. We talked with her for the first time over the phone and introduced ourselves and scheduled the meetings. And although it did take a few weeks and a few calls to help her learn how to open everything on the tablet, we were eventually able to get her to understand how to do so, as well as how to open the features. As time continued, V knew how to open her tablet on her own and utilize the Google search for small things such as looking up flowers, and we're able to help her open the Zoom application and speak with her via video chat. The final session ended through talking with her on Zoom and learning how to use the mute, the camera, and the share screen features. As the students, Megan and I would like to acknowledge and thank all of the professors and all of the coordinators of this project who helped us make this so successful.
Wonderful. Do you have comments from our presenters?
Yeah, so I personally, I learned a lot from the experience. I was able to understand. I've never done telemedicine from the provider side before, and that was a big learning lesson. Trying to help the individual learn how to use the tablet without being able to see what they were seeing per se, because in person is so much different than being on the phone or being on video chat. And it was definitely a challenge, but a gratifying one when we were able to see the accomplishments within our participant at the end of the project. And my partner is not available today. She had a conflicting schedule, so I will be representing both of us as best as I can. So if there are any questions, I'm open to answering them.
Oh, that was very interesting. And just from an OT perspective, kind of what did you think has your participant or your, client really emphasized to you after the fact of what they really appreciated?
I think from my perspective, I can't necessarily speak for both myself and my partner, but from my perspective as a social worker, I think that our participant was really appreciative that we were so patient with her, that we tried to simplify terms, words such as keyboard and tablet sometimes were hard for her to kind of comprehend. So we used words such as alphabet and device to help her kind of understand better, especially with the technological misunderstandings, I guess, that she had. As we mentioned in the presentation, she'd never owned a tablet, so she wasn't aware of a majority of the vocabulary that we attempted to use. And I think at the end, she was able to feel that sense of accomplishment, knowing that she did start to understand those terms. I think I answered your question.
Yeah, no, that was super important. Thank you so much.
Hi, Abigail. This is Frank, the question asker. Wonderful presentation. And I was fascinated by what you were talking about with regard to the jargon and the language. And for this person, it was really learning a whole new technology and language together. And it sounds like you and your partner adapted and were able to change words and language to make it much more understandable for her. And that to me, I think, is really a powerful lesson from this.
Yeah, definitely. We also wanted to ensure that she knew that she was learning more. It was hard to get all of that jargon information in within the short amount of time we had, but we made sure to encourage and acknowledge even the smallest accomplishment, whether it was knowing that she turned on a camera on the tablet, knowing that she understood how to use Google search bars, and even if it was something that seemed straightforward, we encouraged her, giving her the good jobs and the kind of the applause that she deserved for anything that she was able to do with that new tablet.
Thank you.
Yeah, thank you so much. Wonderful presentations today. Is there any final last minute reflections to share?
This is Dr. Chow. I just want to thank you, both of my pain clinic teams. It's really wonderful. We have run the program for 5 years. This is the first time we did a Zoom meetings, and it worked out really nicely. And I'm sure there are a lot of advantages we're going to take in the future as well, even when we get back in person meetings. Thank you all.
Yeah, thank you so much. It was a great experience.
Hello, and welcome to our presentation on an interprofessional approach to telehealth. Our team name is Great Smile. Just to give you some background, Alex, an individual in their 20s, pronouns they, them, their, came to our clinic. Alex was homeless and originally came to discuss their oral and neck pain. They were also experiencing stress related to housing, pain, appearance, and inability to afford medication. Over the course of 2 telehealth sessions, we worked with them to address these concerns, as well as to begin working toward their express goals of becoming employed and entering into transitional housing. Our team members included individuals in occupational therapy, physical therapy, dental medicine, nursing, and pharmacy. This past year, we've learned the ins and outs of telehealth. Telehealth is a way for patients and healthcare providers to connect through technology. It has many benefits, however, it also has its challenges. Benefits include increased accessibility for patients to healthcare providers, as well as students like ourselves being able to attend these interprofessional events. In addition, patients don't have to worry about transportation to doctor's appointments and can see many specialists all in one visit from their own safe space. However, telehealth presents with some challenges, such as difficulty reading patient body language, as well as limitations in assessments that require hands-on care. And it also requires access and knowledge to technology, which we know a lot of individuals do not have. So motivational interviewing is a style of patient-clinician interviewing that we learned and mastered during the IPTE session this past fall. So what does that look like? Interviewers make use of open-ended questions and take a non-judgmental stance, which allows for a patient and/or client to feel comfortable and fully embrace themselves in the moment. Interviewers use affirming, acknowledging phrases and summarize the patient's comments. For example, they might say, "So what I'm hearing is," just to make sure the patient's wants and needs are being correctly conveyed. Reflective listening is also another major component of motivational interviewing. So just some general takeaways. My name is Anna, and I learned how to approach client care in a more holistic way through the lens of other disciplines. Kate found that she was able to learn new things about patient advocacy and empowerment through collaboration with an interprofessional team. Emmeline learned that patient care is best and most efficiently delivered via an interprofessional approach. And Val learned that quality patient care can be provided through a telehealth platform driven by an interprofessional team of healthcare professionals. So that is our presentation. Thank you so much.
Thank you so much. So wonderful.
I had a quick question. When you're dealing with the patient that you introduced in the very beginning, you mentioned that the patient was homeless and kind of in transition housing. What are some resources that we could use for those patients who are interested in telemedicine? Or did you find any? Maybe you're still struggling.
With our particular patient, they did have access to a computer during the sessions. It was a computer they were borrowing, so that was actually one of the things that we had to figure out during the first session. They had their camera turned off for the first half. And it wasn't until kind of the second half when Val, our PT, was doing an assessment that we had a discussion about turning that camera on, and it turned out that it was because Alex, the patient, was unfamiliar with that particular computer. We didn't really discuss in depth how to increase access, since they had consistent access to a computer during our sessions, but I think it's definitely an important thing to consider with telehealth.
And it looks like in the chat that Karen said, were there specific challenges to interprofessional practice in the telehealth setting?
Yeah, I can take that one. There were challenges. Like Kate mentioned in the beginning, the client's camera was off, and we weren't really sure if that was because they didn't realize it was off or if there was a specific reason. So that presented as a specific telehealth challenge. And one of our PT who wanted to see the client perform like certain arm movements or wasn't able to when their camera was off. So that presented as a challenge as well.
I have a question. Having been part of this team process with you all, which you handled beautifully, by the way, and I know I'm biased, but handled beautifully nonetheless. You handle, as a team, I saw you handle situations that weren't always easy, and like with the camera and all of that. But how did you regroup? How did you manage to handle those difficult situations as team members?
I think we did a lot of like planning ahead, kind of talking about maybe some expected challenges that would come up, and then after the fact or during breaks in our meetings with the patient, kind of reflected on what had happened, how to talk about some of the challenges that had come up. So in that first session, we had a break midway through, so we did discuss the camera being turned off, for example, kind of brainstorm some different reasons why the patient might have had the camera off, how we could approach discussing turning the camera on in a way that would still like protect the patient's autonomy, safety concerns, things like that. So yeah, it really was just about taking some time to discuss things before and after every session with the patient.
Mm-hmm. Great.
And there's a really interesting question in the chat from Ellen. How did the client respond to the interprofessional nature of your approach?
So our approach was Kate, who represented nursing. She started the conversation with the client in the beginning. So we felt that having that one go-to person that was always present in the room with the client was very important. So our approach was having Kate there at all times, and then other professionals would filter in once like a referral was made. But having that one go-to person who was able to summarize the end of the session, that particular session, we felt was the most important part of just the telehealth approach to make that client feel the most comfortable.
Yeah, and when we had our debrief with the actor who played our patient, they did kind of say that in particular made them feel comfortable and made them feel like they had that connection, helped them feel that we were working together as a team.
Thank you so much. It was super wonderful to hear
your input and your presentation. All
Thank
right.
you, team. Great smile.
And now we have just a general discussion and debrief. A little bit of a reminder. Today we saw the biopsychosocial dimensions of chronic pain care, the benefits and challenges of telehealth from the pain clinic teams. We saw the telewellness project, and if you team great smile. Floor is open to any and all discussions.
I think we have some students here from the previous presentations. Ellen had asked a question about the client's response to interprofessional nature of the approach for telehealth and telemedicine. And we only got to ask the last group, but if anyone else wants to add their thoughts, I just think it's really interesting. We've talked a lot about our barriers and our perceived barriers of what the client or the participant or the patient has, but did any of you get lucky enough to have a client or a patient or a participant tell you exactly how they felt about the interprofessional nature of your telemedicine?
On a final feedback form for the pain clinic, we did have some positive feedback from our client who had just mentioned that he enjoyed seeing so many different professionals or students in one, and that it was very helpful for the breadth of the students. And I definitely think as a student myself, it was super helpful for me as an OT student to really learn from other disciplines and be there to have that communication within, even if it's just that modeling that you don't necessarily cognitively realize you're doing.
Any other thoughts before I move on? We have another good question coming up. So Ellen asks as well, what do you think is the future of telecollaboration as we inch closer to a post-pandemic world?
I think where I had seen it before COVID and where I think it'll probably continue to develop. For me, I come from Oregon, and the eastern 2/3 of the state is incredibly remote and has very limited access to healthcare and especially specialized care. And so telehealth, sort of telehealth clinics have started popping up where individuals can either use their own technology or go into like a community center that might have a couple of cameras with video capability. And so individuals are able to meet with specialists and become familiar with an interprofessional team without having to make the 8-hour trek to Portland every time. So then when they do make that trek, their collaborative team has had more time to really figure out like targeted approaches to maximize the efficiency of their time when they're in the city.
And I think Karen asked a really a nice segue question, because I think you touch upon some of that, Kate. But for anyone in the room, I'm curious about the challenges specific to working in interprofessional teams in the telehealth setting. So when we're in our training, we often have the extra time to be able to do these collaborations. But in the non-training setting, we may find that all of our schedules don't quite overlap so nicely. So what kind of challenges did you experience, and any thoughts? I guess I'm going to add to Karen's question. Any thoughts about how we might be able to manage some of these challenges?
I guess what I would have to say about this is that, you made a great point. It's definitely going to be, our schedules are very hard. There are obviously going to be times where we all would not be able to meet together. However, I feel like the comeback to that would be that since this is a telehealth setting, the patient wouldn't be as inconvenienced if they had to drive, like, oh, I had to come for an hour to see this provider, and then the next day I have to drive again the hour back to the office to see now this provider versus telehealth, they're gonna be, oh, well, I don't have to drive an hour each way now. I can just do the meeting on Wednesday and do the meeting on Friday or Thursday with the patient at home, and they won't be as inconvenienced. I think that's the trade-off to that.
Yeah, I completely agree. Even just scheduling as students, our schedules often didn't overlap, but the telehealth and Zoom platform definitely mitigated that a bit.
I have to say, what was so striking about a lot of these the work that you guys did is that you were able to kind of meet in the same room often at the same time. So sometimes you had like a go-to person, and then they would you'd add people as you go and as you need. And that's really interesting. And I like to think I work in an interprofessional environment, and I think I do. But sometimes what happens is, the pharmacist, which is myself, I see the patient, and the doctor sees the patient, and then the nurse sees the patient, and then the nutritionist sees the patient, for example. But we never get to see them in the same room. And I think that that's what telehealth really offers the opportunity. Even if we could just put a couple of those professionals in the same room at the same time, that's going to offer so much more. And I think there is opportunities there. And if we if we move towards a model where there's less, we see a patient every 7 minutes, and we get to see our patients for a little bit longer, this will also be an opportunity.
I think that's a really interesting point to think about how we can both use telehealth as a tool, but also learn from telehealth and what it offers to interprofessional collaboration for how that could influence in-person collaboration. I think one example that really jumps out to me in the hospital setting anyway is how closely PT and OT collaborate. I mean, to the extent that many people kind of conflate their roles. Just wondering how other professionals can learn from them and can learn from from telehealth collaboration to increase collaboration in person.
It's certainly obvious to me that you've all learned a lot about telehealth and the advantages and some of the disadvantages.
Yeah, you have all thought a lot about it too. You've provided a lot of insightful points. I think that, some of them seem, okay, yep, there's some basic barriers, but you guys thought really deeply about them. And I'm glad you got the opportunity to open up and let us know what you think.
I also remember that your presentations, your PowerPoints, all those things, it's a documentation of this incredible era that we just lived through. And you all have lived through it, often the first classes. And so keep those documents.
Yeah, thank you, everyone.
Thank you.
Now there'll be closing remarks in the main session.
Thanks, Dakota. Thanks, Sydney.
Thank you. Thank you so much. Nice to meet you too.
Hello, my name is Casey Keys. I'm a second-year comm student with a background as a paramedic in Minneapolis. After the death of George Floyd this summer, I was inspired to fly out to the city and volunteer as a street medic alongside the protests. During my time as a street medic, I saw that a lot of my other protesters had no formal medical education. Upon returning to campus in the fall, I was inspired to reach out to CECE and other allied health professionals to try to put together an event that would allow them and inspire them to use their experience to contribute to times of civil unrest. As a comm student too, I feel like I don't get a chance to interact with the other allied health professions. And this gave me, despite COVID, a chance to interact and collaboratively work together on a project with a number of allied health professionals.
Hi, I'm Bethany. I'm a second-year occupational therapy student with EMT experience in New York and Pennsylvania. Casey did a great job of gathering a whole group of allied health professionals to work with, which was really empowering as somebody coming from an EMT background into this group with lots of different allied professionals to work with that same shared background. As an occupational therapy student on this team, I really focused on preparing to be a medic and what that would look like, as well as the mental health component of providing aid within this context. The other piece is that during the entirety of this project, I was in Portland, Oregon, completing my second level 2 fieldwork opportunity, which impacted when we could and could not meet.
I'm Chris Eidson. I'm a first-year doctor of physical therapy student. I was recruited by Casey and CECE to bring my unique perspective as both an EMT and a combat veteran to this event. Along with that, as a physical therapy student, I really wanted to focus on bringing the perspective of trauma-informed care as it relates to protest medicine.
I am Wyatt Blackstone. I'm an undergraduate here at UNE, and I was recruited by Casey and CECE based off of my experience being an EMT for 3 years, doing 911 transport, as well as a fire line EMT, providing my experiences with environmental hazards as well as triage to this event. I was also able to bring in a lot of the undergraduate community as well as the undergraduate EMS community to this graduate level event. And I'm very happy how this event went, providing education resources to the community inside and outside of the classroom during this event and well after.
Hello, my name is Casey Keys.
Alrighty, and at this time, if anyone has any questions for the team that presented, please feel free to ask. Or if the team would like to elaborate at all, we do have until 12:18 to discuss your poster presentation.
I'm going to unmute rather than be in the chat, and I'd love to hear more about the trauma-informed perspective that you brought into this presentation, because there's no doubt, first of all, amazing presentation. Just want to say that on all levels. But I'm curious about how you infuse trauma-informed practice and trauma-informed skills into the work that you did.
I mean, Shelley, this is something we talked about after the event, but that's a facet that we could have like done a much better. I mean, better, but like we could have explored that deeper. I think a lot of the presentation focused on like the nuts and bolts, and the poster was kind of like the collaboration between us interprofessionally. But that is something that's like extremely relevant for like the post-event de-escalation, debrief, like how to hopefully like incorporate your experience into like a meaningful like narrative moving forward. So I think just like reflection on that, like taking time for self-care like in between, because as my time in Minneapolis this last summer taught me, like engaging in protests like day after day is exhausting, like physically, mentally, emotionally.
And that, I mean, to our credit a little bit, Casey, that was something that we did talk about like in this, like when we were initially planning and like when we were discussing what each of the interprofessional roles would have. I also think, do you have top 3 things you'd want someone to know about protest medicine?
Yeah, I would say first thing, anyone can get out there and do it. Get a tourniquet and some Narcan and a bag of Band-Aids and some sunscreen, and you're good to go. I mean, that's like grossly reductionist, obviously, but I think that's like the top thing is like feel empowered to engage however you want to engage. And the second thing, like right off that, is like there is no like cookie cutter formula for how you want to do that. I think the inspiration for this came from like seeing all the protests that were happening and knowing that I had experience feeling powerless and frustrated and wanting to like engage with the protests in like a meaningful capacity. And that looks different for everyone who chooses to engage with them. But I think it's just because you can be aware of like that full spectrum of how to do it. Then I think that's what this was trying to encourage you, is like these are the information we presented was a variety of avenues you could explore, things you could engage or like dig deeper in. And that being said, like take or leave whatever works for you. And I don't know, the third is I don't know. I can't think of anything snappy off the top of my head.
I think the third for me would be, don't become a victim yourself. Like there is some level of like like yes, you can engage what you want, but like know your scope of practice and know the area, like do your homework beforehand so that you don't put yourself in a position of like danger.
Yeah, and before, like, I know we're running low on time, but the last question, this is different than a typical EMS role, because typical EMS role, you have like a much more like, you have protocols, you have ambulances, you have operations and comms. Like this is a much more like ad hoc, you have to like kind of operate by the seat of your pants. There's no formal communication. A lot of times like phones and typical things like that don't work just due to the number of people there. So it's much more an exercise in adaptability than it is, following standards of protocol, as like the difference between like protest medicine and like formal EMS work.
All right, thank you so much. And just a reminder, we do have time at the end for additional discussion if you have additional questions. All right, and at this time, if the team would like to expand at all, or if there are any questions, please feel free to ask.
Well, I'm going to just do it again, and because that was a phenomenal presentation, very powerful, very relevant, and I'm curious about those of you who put this together, this presentation together, this idea of mobility and going into communities rather than communities coming to established centers. I'm really curious where that idea came from. And also the interplay of rurality here, which, is really important. I'm sorry, that was my dog snoring. I apologize. So I'd love to hear from the presenters.
So how we got started was basically we listed everything we thought went wrong with the coronavirus pandemic response. And then we tried our best to kind of find common determinants. And a lot of that was lack of access to care because either, again, people just did not feel safe to reach out to, healthcare access points. We wanted to decrease the amount of contact they had. So, obtaining groceries, obtaining PPE, competing with each other for this PPE. So we really set like individuals against each other, and it was very isolating for people to try to stay in and not get anything that they needed. So that's where it came from. I'd welcome any of my teammates to add to that.
I have a question. I'm wondering if you had to navigate or negotiate roles and responsibilities as you thought through that.
Do you mean specifically between like state and federal, or the medical staff itself?
The staff, the actualizing your idea.
Yeah. So I think that's where kind of the division between like medical fleets and the social support fleets would come in. So medical fleets, that's kind of already an established responsibility hierarchy kind of thing. So you would have kind of medical professionals, nurses, and then for the social aspects, we would want social workers, psychiatric care where needed, and childcare. So that's where it would kind of need a little more work.
It also looks like there's a question in the chat from Casey saying, did you draw any inspiration off of any previous projects or initiatives? If so, what were the unexpected successes and pitfalls?
So we actually did not. It was really funny because after our initial meeting, I saw after we had already come up with this plan, on my Instagram, I saw that New York City did like vaccine buses. And I was like, well, it must be on the right track. So no, I did not see any other ideas similar to that. And it would have been smart to incorporate any successes or failures.
One thing we liked was we looked online about other resources we could get with vans, and we saw the van concerts through the vans, which we thought was really great for adding the social component, because it's kind of like a moving stage, and it's really good for social distancing. You can kind of make you could have exercise classes, concerts, talent show type things. So some things that people can look forward to in the community. It can be kind of an event that people can look forward to and bring the community together, because we really want to incorporate this kind of the community building aspect as well, not just kind of treating the medical aspect, but really helping the mental and emotional health of the communities as well.
All right, thank you so much. And again, we will have additional time at the end for any other questions or thoughts. Thank you, Wellness on Wheels. And if you would like to switch any between breakout rooms, now would be the time to do so. And here is just another little IPE reflection that we have, and we will move on to the next team.
Hello, thank you for taking the time to read our interprofessional approach to a pandemic plan. In this voiceover, I'll be quickly reviewing the topics we present in this poster. In pre-pandemic times, we put a focus into PPE cycling to ensure several months of supply, financial buffering for healthcare firms and state budgets, identifying alternate roles that staff can fill and training them for rapid redeployment, as well as contracting doctors outside of a hospital's own system to be used as reserves. With regards to disease surveillance, Maine immigrants do not have access to Maine care, which may cause a blind spot through their inability to receive care. Support for Bill LD 718 can resolve this issue. Also, we believe that international cooperation should be pushed for as a changing culture that sees it as immune to diplomatic tensions. With regard to containment and mitigation, the primary concern will be initial containment and identification of the pathogen. Structural healthcare system issues in the United States prevented an immediate and efficient response. Prevention can be supported with overall cleanliness of public places and businesses, reduction in number of live markets, and decreased antibiotic use in farm animals to reduce the spread of infection. Overall, an increase in communication between hospitals and governments will help with current and future infections. We must consider form of government and cultural orientation when assessing successful pandemic responses, because this impacts how much control countries are able to have over their citizens and how many individual liberties people are willing to give up. Vietnam was an example of an extremely successful Eastern country. They were successful through implementing travel restrictions, closing their border to China, implementing strategic health checks, contact tracing, and a 2-week stay in quarantine centers, in addition to closing schools and doing this all very early on in the pandemic. New Zealand was an example of an extremely successful Western country. They were able to do this through excellent communication between government and people, and by striving to find, test, isolate, and care for every case of COVID-19 in their country. With regard to vaccine equity, we focus on fair distribution and making sure that everyone has an opportunity to receive the vaccine. Governments can help to ensure ample supply through tax cuts or direct funding for biotech companies. We also look into different ways of engaging community leaders to help get vaccine to underserved and minority communities. Lastly, we look into open communication and how trust in the government and scientific community can lead to greater rates of vaccination. Each discipline must work together to be successful in any plan. Public health professionals are required for multiple parts, from disease surveillance to policy creation. Most importantly, though, they are a good point of communication for the public. Community leaders can also be utilized as liaisons to providers. Ultimately, communication is key. If you have any questions or would like more information about our plan, please email me at bpastori@une.edu. Thank you.
All right, and if there are any additional questions or comments about the presentation, now is the time.
I have a question. What part of your plan did you find most challenging to try to tackle? And then also, two-part question. How did being interprofessional help you guys tackle that?
For me personally, I think seeing the amount of miscommunication that really went into like COVID-19 with our government, and how we can try and change that for the better, really, like, it was difficult for me to like grasp, because it seems very simple to just present information that is correct, but then it can be twisted and not actually followed. So trying to figure out how to reduce that is very difficult, in my opinion. And then also looking, so I was in the containment mitigation part, and looking at like things like deforestation and animal markets and stuff, and the antibiotic usage in the United States, and how much we need to reduce our like handling of animals when we're sending them out to be used for consumption and whatnot, is a big product of, spreading of infection. So trying to figure out what to do with that also was also difficult, I thought, too, because that's something that I personally can't do, but it's something that we should try and like look into and fix. So if my teammates want to elaborate as well.
Yeah, I think also being interprofessional really helped us to have a good perspective. We had Ben from pharmacy, which is kind of fun to hear his thoughts on vaccine distribution. And then Chandler's PT, and the rest of us are from the COM program. I also saw Dr. Timi's question about conflict of thought or strategy between leadership. And we elaborated about this a little bit more in our full presentation, but I looked into successful pandemic responses. And one reason like New Zealand in particular was so successful was that they were able to come up with this really centralized plan and provide this like frontal leadership and execute this. So I think that that's really important for like successful pandemic response, is coming up with a centralized plan and being able to execute that as like one group.
Yeah, kind of to backpack off of what Savannah had said, I looked into some research that showed that kind of trust in one central government led to higher vaccination rates. So it really just depends on like the culture and how much people trust their government or like the leaders.
I was thinking about the relationship between the Wellness on Wheels and this presentation in terms of thinking about race and ethnicity and more vulnerable populations and the engaging various leadership in promotion. And I'm just curious whether that was factored in as you pulled this presentation together. And I see we only have 1 minute for that very complicated answer, but I just saw a nice relationship between those two presentations.
We
Yeah.
primarily looked into how we could reach out to more underserved communities through community health workers. And we did this through looking at the roles and responsibilities that we generally see with community health workers. And we've seen a lot of people step up to the plate in international settings. And I think that if we were to utilize that as that role and like have more of a program to train more people to be community health workers, we could reinstate some trust in healthcare and medicine and science in general that may have gone by the wayside in the past due to past events such as the Tuskegee trial.
Thank you.
All right, thank you, team 2. And at this time, if you'd like to switch between breakout rooms, please do so. And a reminder that we do have additional time for questions at the end.
Hi, everyone. My name is Sean Callaghy. I'm a first-year medical student with the College of Osteopathic Medicine. The title of our project is Hindsight is 2020, Plan, Perform, Evaluate. So this is a quote from Dr. Schwab. Behind every single one of these numbers of cases is a person. Every one of these cases represents someone's friend, spouse, mother, child, neighbor. So we continue to ask that we treat them with the humanity they deserve. And here's a summary of our project. So basically we developed a multidisciplinary plan that kind of analyzes best practices and kind of failed performance indicators across 4 different areas: education, public health, infrastructure, and mental health, which kind of ties all these things together. And so we use research to show what measures should have been taken to prevent the fallout if such a significant catastrophe might occur again.
My name is Will Rinaldi. I'm a first-year student, College of Osteopathic Medicine here at UNE. Throughout this presentation, we discussed 3 potential plans that are geared towards education that can be utilized in case we ever need to encounter another pandemic, or in case we ever encounter another pandemic or natural disaster, like the one we just experienced. The hybrid model is the best way to assure that we keep schools open for students that need access to vital biological resources, a safe and productive learning environment, and the necessary tools to ensure for a maximal learning experience. Specifically for urban schools, one future direction may be to develop and maintain partnerships with community organizations to prevent food insecurities during the school closures due to pandemics or natural disasters. And then the cohort model, which is a part online, part in-person plan that will promote integrative and efficient learning for all students, regardless of their social backgrounds.
My name is Katie Santinello, and I'm a first year in the College of Osteopathic Medicine. I have my Master's of Public Health and Epidemiology. So I came up with 3 public health recommendations for our pandemic playbook. The first of which is grassroots organizations and investment in them is necessary in order to garner community engagement. Decentralization of recommendations is the key in order to effectively communicate with many diverse communities. Secondly, accurate and timely information sharing that impacts the health of the population must be mandated by global entities. And finally, best practices and globally shared protocol must be available on an easily accessible platform in order to decrease morbidity and mortality regarding research, treatment, and/or immunization.
Hi, everyone. My name is Michaela. I'm a 3rd-year Doctor of Pharmacy candidate. My role here is to discuss infrastructure, which includes the government and our economy. My recommendation is as follows. In order to maintain public health while preserving the economy, our government must provide aligned early public health messaging from public health officials and government officials, create a strong, sufficient unemployment plan with incentives for businesses to stay open, offer support for businesses converting to telework, enforce the requirement of adequate safety measures for employees who must physically attend work, and finally, to offer childcare support for parents who are working to keep employees in their roles.
Hi, everyone. My name is Belle Bogle, and I'm a first year in the Masters of Social Work program. My pronouns are she, her, hers. These are the recommendations for mental health. Studies show that mental illness may soon be the most common pre-existing condition. We must continue to train the next generation of healthcare providers in an interprofessional manner to provide the best client-centered care. Our next recommendation as a team is to integrate mental health into the preparedness and response plans for public health emergencies from the onset. And lastly, we recommend that we should gather more data and conduct research on at-risk populations across all disciplines. We recommend census level data, insurance level data, social service provision data, and the specific pain points that we looked at are access, usage, and stigma. Thank you. At this time, we'd like to open the floor for any questions.
I really liked the integration of mental health into this concept, because I think so many people think about process exclusively when it comes to planning for this. And I see mental health on both sides, both providers and the patient client level. I'm wondering, like, what was the scope of mental health that you envision, or what areas do you think you would prioritize as part of that?
Hi, Dr. G. Thank you for such a thoughtful question. It's really good to see you. So we talked about mental health as underpinning all 4 of these silos, and I have to confess, we only had 30 minutes, right, for our original pandemic plan competition, and we only had 3 minutes, and I can't confess to you how many times we took this darn video. So the outtakes are really funny if anyone ever needs a chuckle late at night. But mental health on the way that we train the future of healthcare providers, from studying for boards, from the way that we're all in exam periods, from how we'll be in residency and clinical rotation, that's super important. But how we come off of the role, and I even remember the first time we all met, it was 6 days after the spa shootings in Atlanta, and even the way I introduced myself to my team, I gave my pronouns. I identified myself as AAPI, which is Asian American Pacific Islander. And the reason that I said what I said is because if we are in a rotation and we are not sharing part of ourselves as the identity wheel, how are we going to show up in a community pharmacy, in the ED, in a social service agency for our clients? And so to answer your question, and I'll popcorn it to my team, we are whole people treating whole people. And so as a higher ed institution, how are we bringing into the classroom real examples like this IPE to remind ourselves and our students that when we go out into the real world, that's what we're doing?
Yeah, and I'll add, I'm Katie from College of Osteopathic Medicine. Thank you, Dr. Dornblaser, for your question. Again, it very much aligns with the osteopathic mentality, right? Treatment of the mind, body, and spirit, just exactly what Belle said, whole people treating whole people. So I just wanted to add that it's very osteopathically minded, and just to make sure you're aware of who you are and what you come to the table with, so that your patients can feel confident in telling you what they need to tell you.
Hi, everybody. I have a quick question. This is Jen. I'm from COM as well. And this is very impressive. I think it's really comprehensive, although basic. I'm not familiar with the context for you creating this. So I'm curious about that, and how you might be able to share it as a model that folks could consider in the future.
So we got involved with this project through the pandemic plan competition that was run by the Infectious Disease Association, which is an interprofessional organization on campus. However, it's run generally by student pharmacists, including Sandra, who's the president. So we got involved and we all came together as a team through that competition, but then we sort of recognized that there wasn't a great amount of guidance for what to do during our current pandemic, and our idea to make this playbook sort of came from all of us coming from different backgrounds, making different recommendations, and wanting to make it really concise and clear for future health professionals to be able to read it and take it, and take away that initial work from getting started with the future pandemic.
Yeah, kind of going off what Michaela said too, I think when we first started this, there were so many different aspects we could have took with this presentation. We had to cut out a couple categories such as, more politics and economics. We actually had to combine government and infrastructure. So I think, it could have been taken in more focused and more towards a bunch of different paths, but I think narrowing it down to those 4 that we kind of addressed during the presentation was a challenge in itself, and one that I think that we kind of executed very well. But yeah, you know, it was great, and it was really nice to see how the interprofessional aspect of this whole project really highlighted each of our respective disciplines, being pharmacy, social work, and osteopathic medicine.
Thank you. That was very helpful.
Alrighty, at this time, I will share my screen one final time. Here is our last IPE reflection from an alumni, and it says, the effective communication with other disciplines allows for better decision-making for all us as professionals for the patient's care. And for the rest of the time we have together, we can have an open discussion about all of the presentations seen today. As a reminder, we have the protest medicine presentation and all 3 pandemic plan competition presentations.
So I'd like to follow up with Dr. Dornblaser. She stole my thunder there with the question about mental health, but this is a sort of a selfish question. I've been talking a lot with primary care providers and other health providers out in the field about the insufficiencies of integrating behavioral health and primary care, that we don't quite seem to have it down yet. And so one of the things we've been thinking a lot about is, and I'm asking really for your advice, is how do we do a better job of integrating behavioral health concept, mental health concepts into all of our health professions? That's number one. And the second part of that is, how do we deliver it? Should it be discipline specific? Should it be interprofessionally, or should it be both? Should we be looking at ways to make it seamless within the curriculum and not an add-on? So that's a big question, but I think every single one of the presentations touched on the need to integrate this knowledge.
Shelley, what a wonderful question. And I'll try to start with one example, and then I'll popcorn it. I want to be cognizant. Something that I read about just this morning that the team is that CVS is doing a pilot study, and they are hiring LCSWs, so licensed clinical social workers, to work in the clinic. And what is interesting is they are partnering with pharmacists. And I sent it to Dr. D because I thought this would be a great, something that I'm always thinking about. So I read something, and now what can I do with it, right? And so I work for the university, and I'm a student at the university. And we had this incredible opportunity with IPE here that, frankly, I know a lot of folks don't take enough of an opportunity. We're already doing 1,000 things, especially in a pandemic. And so what the article touches upon is that maybe you are Susie Smith and you go to CVS to buy milk, and you're also picking up your prescription, but you see some literature, or you're talking to your pharmacist and you say, it's been a really rough couple of weeks, couple of months, and they hear something because they interact with you and they say, did you know that we have an LCSW here? It's really accessible, and that way you don't have to go find a mental health provider, or you don't feel comfortable talking to your PCP about that because maybe there's cultural stigma or cost or whatnot. And so you start seeing the LCSW at CVS. Maybe it's just one visit, but that takes out some access issues. And so this is a pilot that's only in 3 or 4 cities, but so that's a new way to integrate into the community. That's another delivery model, but how does that affect us here at UNE? Maybe that's something that the School of Social Work and the School of Pharmacy can develop a sim lab model so that, you know, Michaela, my teammate, and Belle can partner in the future with. And then selfishly, our pandemic team, all 5 of us have already committed to potentially hitting up CECE for some grant money and taking the legs of our pandemic challenge and thinking about publishing this in a journal. We've already talked to Dr. Tom McLaughlin about a mixed study research of just taking one silo and doing a study on where this can go. So thank you to CECE for putting together an amazing team, and to Sandra for executing on ways to encourage people to work across their silos. We're not an echo chamber.
And I wonder if you could partner with the School of Dental Medicine, because they already have like all the community members coming in. So yeah, that's gonna be a cool project.
I love that, Bethany. And if you could DM me your email, I would love to talk offline about that.
I'm not from this, I'm from OT and I'm graduating, but I'm sure there's
that is a great suggestion.
that would love to work with you on this.
So I'm thinking Dr. D and I need to have a chat about how to create a rotation, not just a simulation, but a clinical rotation at CBS.
I will forward you the email I sent her this morning.
Yeah, I read it though, and I was like, "Ooh, this is so cool."
Yeah, we can make this happen. Yeah, we can make it happen, and we have mini grant money. Just send us a proposal, and it's yours.
I think another thing to add, and I think Belle did an awesome job giving a phenomenal example of that, but I think our students are a generation that's mandating and advocating for our education on these topics in a way that's never been done before. So I think, in College of Osteopathic Medicine, we're suggesting topics for grand rounds, and we're bringing up these conversations in our clinical skills learning. Like, how do we ask someone about their mental health? How do we bring it up in the 15-minute visit? And then if it's not something that we think we can handle, who do we refer to and how do we do that? So I think us as a generation, more so than ever, I think is very cognizant of the mental health roles and the stigma that it has held previously. And we're trying to work very hard as the future generation of healthcare professionals to sort of figure it out first and foremost.
I also would like to just briefly talk about an experience that I had on fieldwork where I was in an acute care hospital, pediatric hospital, and we had no behavioral health member on inpatient staff. It was just outpatient. So we had this patient who was there for 6 weeks, and after 2 weeks for complex regional pain syndrome, and after 2 weeks of OT and PT pushing and being like, yes, this person needs to be up and going to the bathroom, but they're in pain and there's a psych component and we need psych. We finally pulled from the outpatient team and was like, look, someone's gonna have to come upstairs and help us. But they struggled a lot with as a hospital, how do we change our policies and procedures, and the funding to get inpatient psych isn't there. So then it was all a mess, and it's going to continue to be a mess, but at least the conversations are happening.
Well, unfortunately, we've got to go. This is so sad, but meet you in the big room.
Health discrepancies with limited resources. I am Kelsey Pelletier, a second-year osteopathic medical student.
I'm Sarah Bonica, a first-year occupational therapy student.
And I'm Eliza Haniff, a fourth-year dental student.
Our patient is Alex Simpson. She's in her mid-20s. She has a family history of substance misuse and relational losses, and at this point she is effectively homeless and unemployed. She was referred to our clinic. For medical, our patient presented to the emergency department between our first and second visits with dehydration. As providers, we need to make sure we're asking our patients about the physiological requirements for survival. For Alex's medical challenges, she had challenges with transportation, insurance, and medications. She had a comprehensive past medical history, but her chief complaint today was her periodontal disease with visible decay on her front teeth. For medication, she used to take valacyclovir, but it was discontinued due to lack of access. She also takes Tums as needed, which we recommended famotidine. For social, she used alcohol and cannabis for her anxiety. Her support system is her friend Bobby.
So the patient's chief complaint was that her teeth hurt everywhere and she doesn't like the dark spots on her teeth. And she also presents with a burning feeling on the roof of her mouth that is brought on by stress. Her pain is a 5 out of 10 on the pain scale, and it worsens with cold stimuli, and it presents as a dull ache throughout the mouth. She feels embarrassed by her broken down teeth, and she does not have a set oral hygiene routine. So typically when a patient presents to the emergency clinic for a dental visit, we follow an emergency protocol, and that we use that to help draw certain key answers from Alex. Unfortunately, we can't make a definitive diagnosis without x-rays, probing depths, and endo testing. However, we were able to ask open-ended questions to help gather more information, and we were able to connect with her on not only a provider level, but a patient personal level as well. Understanding that not everyone has access to correct materials, it was important for us to tailor a maintenance plan for Alex, and this was fundamental to keeping her trust and improve her oral health.
As Alex was very timid, OT and the interprofessional team worked through the entirety of both telehealth sessions to build a relationship with her and determine which occupations or activities were most meaningful. Those activities were determined to be friends and animals. Her occupational goals were finding employment, finding housing, and relieving her symptoms of pain. The outcomes that we had in the short time with her were opportunities for housing, work, and volunteer, determining her intrinsic and extrinsic points of motivation, evaluating her social environment, providing opportunities to facilitate meaningful occupational engagement, incorporating water into her daily routine to avoid any instances of dehydration in the future.
Health discrepancy.
All right. Hi, everybody. Can everybody hear me? Was everyone able to hear that okay? Okay, great. So that was our first IPTE team, and we invite you all to drop any or speak any questions or comments you have about that presentation, because we have our presenters with us here.
I have a question. This is Sarah Garber from Rosalind Franklin. And my question really has to do with telehealth. And how do you feel the telehealth environment affected this particular simulation? Did it go well? Was it better? Was it worse?
I can go for that one. So telehealth definitely made it challenging. As a DO student, you want to be able to talk to your patients and see your patients and assess your patients. So one of the complaints was neck pain, and neck pain can be a wide variety of things. And without being able to assess my patient adequately, it was very difficult to determine if that was a cause. And what the cause was. Was it related to her mouth? Was it related to an infection? Was it some kind of trauma? Was it a somatic dysfunction? So that was very difficult in that regard. I think as a group, though, we did a very good job with like being a full relationship with our patient and informing that relationship. We were able to get information out of Alex that otherwise maybe even in person wouldn't have gotten out of her. So.
Yeah, I just wanted to add to Kelsey's point that it was a great experience for me because in dentistry, I think that telehealth is kind of a new thing that's going on, and especially when the pandemic hit, a lot of the schools started adopting that mode. But again, I couldn't really gather as much diagnostic information as I would have otherwise without, gathering x-rays and clinically examining her, since this was a heavily dental case. But at the same time, it was great. And it kind of puts things into perspective as far as the interprofessional or the importance of interhuman touch, putting your hand on somebody's shoulder, or just that human kind of way of patient-provider interaction, things like that.
I'll go off of what both of them have just said, because I agree completely with Eliza and Kelsey, because it was really hard to form that relationship with her. She was a very timid individual, so it was hard. But also on the other hand, we got to see things like her home environment and stuff like that, which we might not have been able to see had she come into the clinic. So that was an interesting point of view as well.
Those are really, really good points. How do you think it was for her? Do you think because she was so timid, it might have been easier or harder for her?
I think maybe, so in the first session, her camera was down on her face, but when we told her that, it was an accident. So we didn't know. So I think that maybe made it easier for her because she didn't have to find transportation because, like we said, she was homeless and staying at a friend's house. So I think that probably brought her ears down. But the actual technological aspect did get her there where she didn't even realize her camera was hard to even gauge that.
All right, I'm going to thank you so much for sharing that all. You probably all saw the broadcast message. We're all about to go into the next presentation. So you are all welcome to stay on here, or if you wanted to visit someone else on a different track, you're more than welcome to do that as well. And we'll see you back here in a little bit. Thank you.
We did our poster on our IPD experience, entitled our poster, The Interprofessional Collaborative Approach to Treating and Supporting an Underserved Patient Through Telemedicine. We had Elena George, a social work student, Miriam Lakhani, a dental student, Tamara Brusso, a physician assistant student, and Sarah Manuels, a pharmacy student. The patient was a 20-year-old non-binary individual who was seeking treatment for dental pain through a dental office, who was then referred to a community health clinic for further physical and psychosocial evaluation. I will now talk about our interprofessional collaboration and learning points. Elena.
Go ahead. So Alex was greeted by the team with unconditional regard in hopes of creating a safe space for dialogue through open-ended questions. Balancing Alex's motivation to change by placing value on the importance of the issues and the confidence in changing current behaviors.
As a pharmacy student, we assess the patient's current medications used for both OTC, prescription, and recreational use and supplemental use, and ensure the medication's appropriateness due to current and previous indications.
For dental, we assess the patient's level of decay through open-ended questions, explain the difference between gingivitis and periodontitis, and counsel the patients to not eat sugary foods or Tums before bedtime without brushing teeth.
As a physician assistant, we assessed the patient's chief complaints and then provided home therapies and did the Epley maneuver over on the right while the patient was at home and we were on telemedicine. We'll now look at the process of motivational interviewing and the context clues that helped us treat the patient.
As pharmacy, I picked up on the context clue of a lot of stress that revolved around the cost of the medication, so it allowed me to see that the patient was struggling with insurance coverage, which allowed me to guide the patient in how to enroll for Medicare and Medicaid.
Accepting Alex's ambivalence by their visual cues of physical distancing through wearing their hood and going off camera multiple times. Developing a partnership with Alex by evoking strengths and use of reflective listening skills was critical.
Alex was drinking a beer during the second encounter despite their pain, GI upset, and vertigo, which prompted questions about alcohol and substance abuse.
The patient had a lack of access to dental care, so strategies were discussed to make it easier for the patient to brush and floss twice a day or as regularly as possible. And relationships were basically discussed between sugary and acidic food at night that the patient consumed.
Lastly, we just want to go ahead and thank both Dr. Danielle Candelario and Dr. Nancy Jo Ross for guiding us through the process of practicing interprofessional medicine. These tools that were provided in this process will allow us to build both professional and personal skills to allow us to be successful healthcare professionals in the future.
All right, thank you, Integrated Access Allies. Does anyone have any questions or would anyone like to share? Or any of the team members want to introduce themselves?
I think it's just two of us here, but I'm Tamara, the PA student.
Hi, I'm Miriam. I'm the dental student.
Great.
How did you guys like working with each other over telemedicine? How did that work?
I think it went really well. Oh, go ahead, Miriam.
No, go ahead.
I think it went really well. Definitely learned a lot of things. I mean, from a PA perspective, I think first of all, learning what Miriam does in her dental clinic, but then also what our social work and OT students were doing was really, really helpful. Also being able to talk to our pharmacy student was just like overall useful in terms of figuring out questions with like insurance.
I think the experience was fantastic. I think, again, it was a emphasis that providing patient-centered care, not just specific to your discipline, but what the patient needs and all aspects to provide. To be able to provide that holistic care definitely requires collaboration with other profession, and knowing how to do that efficiently is very important. So I'm just very grateful that we were able to have that experience to sort of practice that beforehand.
Do you think it made it easier for the patient in this scenario?
I think it was great that the patient had, access to people that have different strengths. Like I know that our patient in particular said that they got a lot out of not only having like medical and dental, but the resources from the social worker and the OT student right there. Also, our patient didn't really know what their options were in terms of healthcare, considering they were homeless. And so the pharmacy student was really good, like able to have a long conversation about what health insurance options were available to them.
I think it was also really important because since this case was very dentally involved, and I think the team before us talked about how there was, lack of access to the current radiographs. So there was no real way for us to be able to assess, caries or things like that. But just the patient came in with, such a lack of understanding that, okay, what is going on? Why is my mouth hurting? And then there are all these other things that are happening. What can I do to make sense of it? Like, where do I need to start? And I think that's essentially the issue, that, laying down the steps for them, that this is what you can do this week. Maybe this is what we're going to tackle next week. So having that plan laid out, the patient really appreciated that. And then dentally speaking, having the understanding that, okay, if my gums are bleeding, what possibly could be causing that? If my cusp fractured, which, any part of the tooth, what could be causing that? So earlier in the video, when we talked about, assessing the patient's dental level of decay through open-ended questions, was just to help them understand, what's going on, and what are some of the different diagnoses that we are considering based on what the patient presented to us with. But having that additional information, definitely the updated radiographs would have helped for sure. But nonetheless, I think the patient appreciated having a plan laid out for them.
I do think it was very helpful, since not all of us were in every encounter. I think I may have been one of the first people to notice that our patient was drinking a beer during a physical exam. And so I was able to send a chat message to the pharmacy student and kind of be like, this might be a good time to ask some questions about substance abuse, because our patient was saying that they were in extreme pain and was nauseous, but then came to a medical appointment with a beer.
Sorry to cut you off, but that's time. We've got to transition to our next presentation. Thank you so much for presenting, and everybody is welcome to stay on if you'd like, or to go to a different track. We'll see you guys in a little bit.
Hi, my name is Evelina Stanek, and I will be presenting with one of my teammates, Michaela Busak, about our entire team's experience of exploring interprofessional teamwork and patient care via telehealth. So our objective was to perform telehealth assessment through motivational interviewing and create a care plan as an interprofessional team for a patient experiencing multiple health needs and barriers to access. So our patient, Alex, is a Caucasian male with a past medical history of oral herpes, periodontal disease, vertigo, tinnitus, digestive symptoms, and mental health struggles. He presented to us with pain in his oral cavity and a burning sensation that has been present for a while, but worsened over time. He previously took medication for oral herpes to help with the pain, but has not been able to fill his prescription due to healthcare and health insurance loss and financial inability. He also had complained of other medical needs and symptoms, including heartburn and abdominal pain. His lack of housing and health insurance, as well as access to transportation, has prevented him from being able to see a doctor and a dentist. And his inability to get access to clean water has also resulted in emergency department visits from dehydration. So our goal for the first visit was to build rapport and clarify Alex's concerns and priorities, explore and verify his chart history, and to start a structure a treatment plan. And the goal for our second visit was to develop more of a concrete health plan and to support Alex's strengths. We also tried to explore some ways to use his friend, Bobby, as support to help Alex.
Based on Alex's own reports of his priorities, we identified two major areas of need. First, his oral and dental health was an urgent need, and second, he needed to have some support in place to be able to follow through on appointments and care. Between our first and second session, Alex was able to get main care all on his own, so that was a huge hurdle that we did not have to navigate as a team. Once he had insurance, we were able to easily refer him to the UNE Oral Health Center to get his dental needs taken care of, and we also referred Alex to the Portland Community Free Clinic based on its proximity to Preble Street, where he already went frequently, to establish care with a PCP, and he was enthusiastic about both those options. His friend Bobby was also excited about providing transportation and supporting Alex to make it to his appointments. And finally, Alex stated that he would be able to think more about employment and housing once he was in less pain, as his pain was kind of dominating his life at that point. As an interprofessional team, we learned a lot through this process. The telehealth environment was new to us, but was actually really beneficial as we were able to have multiple providers meet with Alex all at one time, and he was able to have pretty easy access to an appointment when he wouldn't have been able to necessarily get to an appointment. We learned a lot about the patient-provider relationship, building rapport, and really listening to Alex's story and his own priorities and needs rather than just the referral, as they were fairly different. We worked a lot on our interprofessional collaboration and learned a lot about when to step up and advocate for our own profession, and also when to step back and realize that what was needed was not necessarily within our own scope of practice, as well as when to refer to other providers. And finally, the actors that played Alex and Bobby both gave us some really excellent feedback about the way that we interacted with them and how we can improve that we will all be taking into our future practice. Finally, we just want to acknowledge our faculty mentors who were such wonderful supports, as well as our student facilitator and the other member of our team who was unable to join us tonight. Thank you for listening to our presentation about our interprofessional team immersion experience.
All right, that was the IPTE team Optimistic Otters. Thank you for your presentation. And we'd like to open up the floor to see if anybody has any questions for them.
I have a question for you, as always. What did the actors pick up? What were they suggesting?
I think one of the big things that came out of the feedback from the actors was use of jargon, which is something I think we all learn about in our programs, like don't use jargon with clients, but it was really helpful to hear about words that we don't necessarily think of as being jargon, just like medical terms. This came up a couple times just with dentistry terms that I think like us in the healthcare profession, we were like totally comfortable with, but just like raised a little bit of a flag for our actors. And then also there was some feedback around just wanting to know a little bit more of what our plan was, which I think was hard because as students in the IPTE program, we didn't necessarily know exactly what our plan was at that time, but just a little bit more communication around like, this is what we're going to be doing today. This is what we're trying to get to, stuff like that.
Michaela,
Yeah, well said, Michaela. I was just going to add to that a couple of examples of the jargon that our patient was uncomfortable with was radiograph and PCP. He didn't know what PCP meant. So when we said, let's find you one, he said, what was that? What is that? Just for everyone's reference.
What was maybe one thing that you really liked about doing it in a telehealth platform, and one thing you really didn't like?
I mean, I think in this situation, one thing that was good about it was that like one of Alex's main barriers was transportation. So knowing that we were able to see Alex because of the telehealth platform was a huge positive. And for me personally, I found that the like figuring out the dynamics of the interprofessional and like interpersonal workings was more challenging via Zoom. Like we got there, but it took longer than it would have to get in a flow than I think it would have if we had been in person.
Thank you.
What was, maybe length of time answers this question, but what was, like if you were to do this again, how would you get in that flow differently or faster within the telehealth context? And maybe there's nothing you could have done. I was just curious.
So I think that the uniprofessional meeting is really helpful. So I think if I could get done again, so before the meeting, we're gonna we as a group, we're gonna meet first before meeting the patient. So we have the plan layout. So make the communication or conversation go smoothly.
All right, we'll have to pause there real quick because we're about to transition into our next presentation. Thank you all so much for your presentation and for answering such really great questions as well. So for those of you who are here, if you'd like to stick around for the next session, please join us, or feel free to go to another session if you'd like. See you all in a little bit.
So for our presentation, we focused on motivational interviewing to assess how medical, dental, OT, PA, and social work providers can work interprofessionally to create holistic treatment teams for patients within our communities. As a student social worker, I use MI to assess and treat patients' mental health.
Hi, I'm a dental student and we use MI to help improve patients' overall oral hygiene through improving brushing techniques and flossing.
Hi, my name is Kelsey and I'm an OT student, and we use motivational interviewing to understand what activities or tasks are important to a patient and how to change their thoughts or behavior.
My name is Christy, and as a PA student and as well as for physician students, we can use MI for various patient complaints and to help patients reach their health goals and adhere to treatment plans.
Hi, I'm a student physician. Motivational interviewing can be time-consuming to learn to use effectively, but in the long term, it's more productive and efficient than typical methods of change with patients. Just even getting the patient to talk about change, even if they aren't ready to make changes, can be progress. So with all healthcare professionals using this approach and communicating progress with each other, huge changes can be made to a patient's health.
So for our presentation,
All right, thank you so much for that great presentation. And once again, we'd like to open up the floor to see if anybody has any questions for this team. I know motivational interviewing is a very fascinating topic, at least for me. Does anyone have any questions? If you have any team members present here, if you'd like to share how your experience was and what you learned about from each other's professions, maybe a fun fact you learned about each other's professions during this project.
Hi, I'm Megan. I'm the dental student. And I really appreciated this experience because I love that we were able to work with other health professionals. And I can see how positive that can be for a patient who has several conditions. And I think if we keep in touch with these other health professionals in different disciplines, it can really help bridge the healthcare continuum for that patient. If anyone else wants to speak to that, they can.
I think there's a question in the chat from Tom User. If one of you presenters are able to answer that question.
Yeah, my name is Kelsey and I'm the OT student in the presentation. And I think a big component of motivational interviewing that we used a lot was empathy and just understanding our client. Her name was Alex, and just understanding her situation and how she feels. Instead of trying to fix everything at first, just seeing what her concerns were and talking to her and then making decisions and going from there.
I have a question. In the telehealth format, how was it establishing relationships so that you could ask these open-ended questions and make your motivational interviewing technique work?
I think that one thing that we tried to do was all introduce ourselves and make sure that Alex felt comfortable and felt comfortable in the setting and talking to us so that she would be able to open up and answer any questions that we had.
I think also, I don't know if anyone else wants to speak to that, but I felt like I was really trying to be more expressive so that she could read, or the patient could read our emotion and show that we're really there for her or the patient. And it just felt more exaggerated because you're on a Zoom format and you don't want that person to think of or interpret it the wrong way.
Are there any other presenters who would like to share about their experience or what they might have learned about other professions?
Can I ask a question, Michelle?
Absolutely.
So I'm just curious. I might have missed this because I came in a little bit late. I got kicked off. I'm just curious. What was it like dealing with difficult subjects with this patient through telehealth? Because I know Alex has a lot of significant issues to deal with, and I just wonder what it was like managing some of those difficult conversations with them.
Well, from what I remember, it's been a while. I think regurgitating what the patient said really helps us to communicate and understand the patient better. And if that was correctly interpreted, then we could move on in terms of navigating her issues and making sure the patient feels acknowledged too is really important. If anyone else wants to speak to that, they can.
I think what I was asking is, what was it like for you as a practitioner to have those difficult conversations?
I think it was a little surprising at first, like we weren't expecting it, but once we knew that it was more difficult, we were ready to answer her questions and just to understand where she's coming from, and we got more used to it eventually.
Okay, well, with that, I think we'll pause here because we're about to segue into our last presentation. So thank you so much, Hopeful Healers team, for sharing your presentation and for answering all these great questions in this conversation. So stay on if you'd like. As you could see from the broadcast message that was just sent out, you can stay on or you can navigate to another room if you wish. And we'll see you back in a little bit. Thank you again so much.
We are Team 6, and this is our project on technical difficulties associated with interprofessional healthcare through telehealth medicine. Telehealth is becoming the norm in some practices due to the current COVID-19 pandemic. It may look great on the outside by providing access to healthcare providers by the click of a button, but for many people, this is not possible due to lack of technology and stable internet connection. For those who are able to participate, there are a multitude of things that may go wrong.
Hi, Wes. Thanks for coming in today. Oh, I think you're still muted. Yeah, there should be a button in the upper right-hand corner of your screen.
Yeah, okay, thank you.
Okay, perfect. Good job.
Hi, Wes.
Sorry.
Sorry.
Oh, wait.
I'm not sure which one of you I'm supposed to be listening to.
Go ahead, Becca.
Sorry, just wanted to ask about your arm pain. I was just wondering if you could describe it a little bit for us today.
Yeah, so it's kind of
Oh, I think he froze. Wes, are you still here with us? Can you hear us?
it goes shoots down through the. Oh wait, sorry, did my screen freeze?
Yeah, so it was a little jumpy.
All right, that happens. Yeah, thanks.
So can you tell us a little bit about what's going on with your wrist?
Yeah, I'm concerned that I might have heard it again after there's somebody else in the room with you?
Oh yeah, he's just looking for his shoes. They're at the front door.
I'm talking to you about medical stuff. Like, is this kind of personal?
I'm sorry, he just had one question. But we can continue.
Okay.
So is there anything that's been difficult for you to do throughout your day?
Well, yeah, like washing dishes and stuff can be hard sometimes. And
Okay.
Are you getting texts?
Yeah, I'm so sorry. Somebody's going through something. Just try to ignore that if you can.
I mean, okay, I just thought you were like, aren't you here to be helping me?
I am. I'm so sorry. There's no way to turn that off. I don't know how.
What we've just seen are examples of a few of the things that can go wrong with telehealth, technical issues, and other such issues that can come up. Thank you.
All right, that was Client-Centered Chameleons, IPTE Team 6. Thank you so much. We now welcome the comments and questions that people may have in the chat.
That was almost painful to sit through, but thank you.
What was the big takeaway with that presentation? Would any of the team presenters like to share how it was putting that together and their thought process while they were going through it?
I have a question.
Sure.
Okay, so I thought it was very creative as well. And I'm wondering if any of you have actually experienced that as a provider or as a recipient in telehealth and how it felt to you.
I guess I'll speak first. So I know in our interprofessional team immersion experience with our client in the first couple rounds, I think it was a little we needed some practice with our telehealth. So we did experience like talking over each other, not not quite as many as the difficulties that we showed in this video. But I guess the highlight, we just wanted to show everything that could go wrong, even though we hope that none of these things may happen in everyone's telehealth experiences.
I can say
I think it's more in the sense like a lot of people do like talk about how great telehealth is and how great like all the good things that can come out of it, but a lot of people kind of just oversee all the things that could possibly go wrong. So we just kind of wanted to present to everybody, be like, oh, like this could happen, or like somebody could walk into the room and it's really not like a very like private area, but you need to make sure that you let your patients know that it's like, this is a private area, you are safe to talk about whatever you need to talk about and all that kind of stuff. So
Marissa, what did you learn about other professions on your team?
Well, me and Becca actually worked a lot together, and she's nursing, and it was kind of cool to see how much they overlap. I'm in the PA program, so it was kind of like she would help me a little bit in this sense, and then like we'd kind of go back and forth off of each other, but it kind of like we were kind of parallel with each other the whole time. So it was pretty cool to see how much of that overlaps.
We do have some comments in the chat. Many people are saying that yes, technology is not always on your side. That is for sure. How about Rebecca? How was your experience working on this project with, what did you learn from other professions?
I think I'll definitely agree with what Marissa was saying, like since we worked most together throughout the case, but I would say I learned the most about social work. Wes really shed a light on like all the different aspects of social work that I really didn't know at this stage of my nursing. But it was really awesome to hear from him and see what he brought to the team experience.
So if you wanted to give people a heads up about telehealth, you have an excellent example of all the things that could go wrong. Are there things that are beneficial about it that you would also talk about and recommend?
I think part of that depends on the department that you're in or the field that you're working in. We did have a few of those discussions as we're kind of getting started. And I know for me working in social work, some of the, because it's largely conversational based. And so telehealth, I think, can work a lot better than it can for some of the other, practitioners that were in the group. So I think that there are definitely some things you can kind of plan for and prepare for. Like I have had the freezing screen thing happen a number of times with clients. And so I try to just remember the first time I'm meeting with somebody to kind of say, if I freeze or if you can't hear me, just like point to your ears, I'll see that and, we'll eventually come around. And so there's some of those things, but I do think it's very different depending on what field we're in.
I'm curious to know, for those of you who are watching this, how long did it take for you all to realize that this was scripted? Because for me, I think it was halfway through and I was having this panic because I was coordinating all these videos. And for me, it took me about halfway through till I realized, oh my gosh, this is all script. This is all acted.
I'm with you. And at that point, I started smiling and really realizing how good it was. But it was painful the first the first half of it.
Absolutely. Absolutely. Well, any closing thoughts? We have a little less than 30 seconds to go before we're all back into the main room, where we welcome you to stay on for a couple extra minutes and some recognition. But if anyone has any closing thoughts, please share.
I think it was great listening to everything. It was wonderful. Really good stuff.
Great teamwork, it looks like.
Yes. And communication too.
Absolutely.
So in the hopes of completing this in a timely fashion, we're going to get started again. Thanks, everyone. So as we all know, the pandemic brought new challenges and exacerbated any that already existed. And so today's CECE presentation recognitions are to acknowledge teams that address the thorniest issues that we faced really head on. And so we're thrilled to recognize some of the outstanding presentations shared with you today, with a certificate of achievement and a $25 gift card to the bookstore, which will go to each member, one to each member of the team. So for compassionate teamwork in the face of this year's daunting social and public health problems, our first recognition is for a team working with patients living with chronic pain. And I'd happy to introduce Kelly Fox from the School of Social Work to say a few words about this team's work.
So I just wanted to recognize this team for the work that they've done together. I think this was a new challenge for us working on telehealth, and they really rose to the challenge, and they did a fabulous job. And I love that they found the grains of what was good about working in telehealth, as well as the difficulties. So I think they did a magnificent job, and I was delighted to be a faculty member working with the team.
All right, Pain Clinic team, thank you for your work. So thank you, Kelly and Ling, for your mentorship also of this team. And now I'd like to introduce Karen Hussman from the Health, Wellness, and Occupational Studies program. Karen, can you say a few words about the interprofessional team who brought us the ripped from the headlines CECE event?
Yes, thank you, Chris. I'd like to say congratulations to Casey Keys, Wyatt Blackstone, Bethany Gruskin, John Caswell, and Chris Eitzen. This combined graduate and undergraduate amazing team all shared previous training and experience as EMS and EMT service providers. They worked together to create and present a student-led CECE event in February, which was titled Protest Medicine, How to Leverage Your Role as a Provider During Civil Unrest. What an insightful and timely presentation it was. The event outlined detailed strategies and safety precautions and has since been followed up with more workshops across campus on Narcan, Stop the Bleed, as well as planning for a new university-wide focus on trauma-informed care. So excellent, excellent work.
Thank you, Karen, and thanks to the Protest Medicine team. You really, you planted a lot of seeds with that presentation, and we're thrilled to see that come from a student initiative. And finally, as you know, if you've been following along this year, we believe it's important to approach difficult situations with humor whenever possible. And so we'd like to ask Mary Obi from Dental Hygiene to tell us a little bit about your team.
Congratulations, Team 6. I'm just so proud of you to bring the hilarious views of what could go wrong during technology. So thank you to Marissa, Muriel, Wesley, Jaya, and Rebecca. I'm just so proud that I was part of your team. They worked together at the client-centered chameleons, the technical difficulties associated with interprofessional telehealth medicine. And as I watched them present, I saw everybody smile behind the Zoom screen. And I'm so proud of you. Congratulations.
Thanks, Mary, and thanks to the chameleons for taking the chance, taking the risk, and hitting it out of the ballpark. So thank you all so much for attending today, and to the faculty for mentoring all of this complex student work. Congratulations and good luck to our graduates and to everyone who has achieved the honors distinction this year. Great work under difficult circumstances. We look forward to seeing all of you who are returning in the fall back with us again. And if you haven't completed the attendance survey, we would love for you to do that. Give us your feedback. This was an experiment, these different breakout rooms and doing it this way. And we'd love to hear how that felt for you. And I'm just going to put up the final slide and say thank you so much. And I hope you have a really terrific day.